Welcome to an hour of HealthMade Radio. HealthMade is a community for natural health seekers where we educate people about common health conditions and share extensive research on the most effective natural health treatments and promote legislation that protects our health freedoms. A core concept belief is in the innate intelligence and healing power of the body, and if properly supported spiritually, emotionally, and nutritionally, it can find its way back to health. HealthMade Radio will bring information from integrative health experts throughout the world. Health is what you make it. I'm Dr. Michael Karlfeldt, and I will be your host. Today's guest is Dr. Ryan Cole. Dr. Cole, it's such an honor to have you on the show today.
Thank you, Dr. Karlfeldt. It's an honor to be here with you. Thank you.
Thank you. So tell me a little bit about your background. I know we're going to be talking a lot about this vaccine, the so-called vaccine that we're dealing with, and a little bit about COVID and so forth. But tell me a little bit about your background and why you would be an expert talking about this.
Certainly. So I'm an anatomic and clinical pathologist. I also have subspecialty fellowship training in skin pathology as well. Now, part of my clinical pathology training covers virology, and then early in medical school, I was an MD PhD candidate, so I also did PhD research in immunology. So I have a background in immunology and virology. Over this last year, I've done about 100,000 COVID tests, so I understand the laboratory side of COVID quite well. And that pathology training I did at the Mayo Clinic. So the highest volume pathology laboratory in the world. So I had a really good exposure to a lot of different diseases and understanding diseases and their mechanisms. So this is within my realms of expertise.
So I'm curious, we were chatting a little bit this weekend, and one of the fascinating things that I was hearing is that since the introduction of this COVID vaccine, you've seen a lot of changes in tissue samples, and they're seeing a lot of changes in patterns with certain diseases since then. Can you tell me a little bit what have you seen differently in your lab since the vaccine's been rolled out?
Yeah, and this is highly concerning. There was a paper out of the Netherlands, and I think there was one out of Germany as well, that discussed the blood profile patterns. So in our body, we have our red blood cells that carry our oxygen. We have our platelets that clot. Then we have our white blood cells that fight off different infections. And we have lots of different types of white blood cells, T cells, B cells, mast cells, eosinophils, kind of your Pac-Man cells, your monocytes. But what we're seeing in some of these studies is that the ratio of these cells post-vaccine are shifting. And normally we have this broad array that's set to fight off anything, be it a fungus, a bacteria, a virus. But after the shots, we're noticing that the profile is favoring fighting fungus, but weak against viruses. So what we're seeing at a alarming, to be quite honest, an alarming uptick is latent viruses, herpes family viruses, mononucleosis, shingles, human papillomavirus, molluscum contagiosum virus. We're seeing a huge uptick in the laboratory of all these different viruses at rates that we normally don't see them, and it seems to be in the post-vaccinated patients. Now, I don't know how long this altered immune profile is going to last in these individuals. The studies only did them out for a couple of weeks, but didn't look at them for months on end. But in the laboratory, we're starting to see those patterns of a drop of an important cell. It's called your CD8 T cell. It's your killer T cell, and that's what keeps these viruses in check. Well, additionally, that line of killer T cells is also responsible for keeping certain cancers in check. And interestingly, I am seeing a large uptick of certain solid tumor cancers in the laboratory. Certain cancers, female cancers, uterine cancers, I'm seeing at a 10 to 20-fold increase of what I normally see year to year. Part of that may be because, some people weren't able to get in during their office closures last year, but a lot of these offices have been open for quite a while now. So it seems to me that, and I'm doing studies, we're doing, particular molecular studies in the laboratory to try to link these things. Right now, it's fairly sound science what's causing a shift in the immune system. I'm starting to see some of the after effects. So not just myself, my colleague that works with me, as well as several other pathology laboratories, we're seeing these same patterns, and we're working together to correlate these. Unfortunately, it's very concerning.
So, here you're then introducing a vaccine, and everyone's thinking in their mind, I'm protecting myself against virus. So this is an extra layer of protection. But what you're telling me is that in essence, you're seeing a reduction in the body's ability to fight off viruses, and then also you're seeing then a downregulation of, you're talking about this T cell or part of the immune system called CD8, and which helps a lot to control cancer. So you're actually, all of that is it's like we're suppressing our immune system with this vaccine.
At this point, it appears we are. And the sad thing is prior to the implementation of these vaccines, we didn't have good animal studies that had been done previous. So, we're pushing forward in a very, I think, pressing manner with shots for which we don't know the long-term side effects. Most vaccines, when they come to the market in development, we look at 5 to 7 to 10 years of safety data. And here we did 2 months of quick safety data. We didn't look for, cancer signals. We didn't look for fertility signals. We didn't look for autoimmune signals. We just said, oh gosh, look, 2 months of data seems to have, some efficacy. Let's push forward with it. But unfortunately, because we didn't have those side-by-side studies, now we're starting to see the effects, but not in lab animals, in human beings. And so these patterns are, again, they're just starting to manifest themselves in a predictable manner. And as one gets the shot, some of these natural broad immune responses that we expect are shifting into a weakened pattern.
And so it's almost like we are rolling out this vaccine based upon an assumption, kind of a theoretical assumption that this is how it should work. But when we know with manufacturing of drugs, you always start with some kind of theoretical assumption that it's going to work in a certain way, and then it goes through all these different phases, different phase trials. I'm curious, so people know. What kind of percentage that starts on with the assumption and kind of steps into that preclinical trial and then make it out on the market? Is that a pretty high ratio, or is that very low?
No, the ratios are very, very low of the medications that make it to market. And it's interesting, we're using a platform, this mRNA technology, that was actually developed as a therapy, not as a vaccine. So in certain cancer and genetic conditions, mRNA technology was being used as a therapeutic. Well, in certain large federal and international organizations, they redefined what a vaccine means. And so instead of saying, oh, well, this is a therapeutic modality or a therapeutic agent, they're allowing it to be called a vaccine, but really it was developed as a therapy mechanism. And even at that, it wasn't having whopping success as a cancer therapeutic. It was having trouble in the animal trials they were doing with other mRNA sequences for genes in cancer and genes in certain genetic congenital type conditions. And then the problem, even the inventor of this technology, Robert Malone, MD, he's been speaking out saying, look, we shouldn't be doing this to a society right now. The long-term effects he had been seeing in his research over the years was autoimmune type reactions within his animal models. And it's predictable that we are going to see these coming down the road as well. It was interesting. I overheard an administrator at one of the large local health systems when the vaccines rolled out. He said, well, everybody get ready for the autoimmune disease. So even upper-level management clinicians within large health systems, they know this is going to happen, and they know this isn't prudent what we're doing. And yeah, because of the signals we get early in drug and therapy development, most drugs don't make it to market because we do see those concerning safety signals early, and we halt it, and those never even make it to market. Interestingly, with coronavirus vaccines, when we looked at SARS-CoV-1 and the MERS virus, in the laboratory animal setting, 20 years ago, 10 years ago, 12 years ago, on some of these, we were able to get the animals to form an antibody, but when they were re-exposed to a wild-type variant of that SARS-CoV-1 or that MERS virus, they ended up with hyperimmune reactions down the road, from which many of these animals died, and then others ended up with these horrible inflammatory lung infiltrates. So in the development of even just vaccines, and those were more traditional vaccines, we know when one is exposed to a spike protein from this coronavirus family that spike protein can be pathogenic in and of itself. So now we're giving a sequence that makes this protein, the sequence hijacks our cell to put that spike supposedly just on the surface of our cells within our arm, and then we are supposed to make an antibody to it. But the spike protein, there was a study from the world-famous Salk Institute that developed the polio vaccines, and there they injected animals with just the spike, and the spike caused the same inflammatory conditions that COVID itself does. So it caused vascular inflammation, it caused lung inflammation, brain inflammation, liver, kidney inflammation. So we're giving a sequence that makes a protein of which this protein literally causes disease. So we've always failed with coronavirus vaccines, and last year in congressional hearings, some of the prominent vaccinologists even warned, look, we need to proceed with extreme caution, slowly and stepwise. And instead, we plowed forward too quickly, and now we're seeing tremendous numbers reported of death, over 11,000 as of this weekend. And that's just in the United States, over 17,500 in Europe, thousands in the UK. We're seeing lots of deaths in the European reporting system. They have over 1.4 million adverse reactions, 50% of which are serious. Here in the United States, as of this weekend, it was over 438,000 adverse events reported. And we're seeing these, and these are supposed to be red flag systems that say to us, we're working on something, and if we see a signal, then we're supposed to pull back scientifically, morally, ethically, and say, wait, we're seeing a very adverse signal from this therapy, this drug, this shot, this vaccine, whatever it may be. We're seeing that, and for no good reason, I don't understand why they haven't halted, paused. These are the type of signals. We've had more deaths and adverse reactions reported in the last 6 months than we have in all the 30 years, all the vaccines combined in these reporting systems. So it's tremendously concerning from a scientific point of view that we're ignoring extreme harm signals from something that at this point makes no sense to have it on the market.
No, I agree. We're going to take a quick break. You're listening to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Ryan Cole. We'll be right back. Welcome back to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Ryan Cole, and we are discussing the COVID shot, the COVID vaccine. So you were talking about this mRNA technology and how that was really not meant to be used as a vaccine, and that it was more to be used as a kind of a therapeutic intervention. So with that being said, I mean, because with a vaccine, we are wanting to trigger an immune response so that you are then immune to certain things. So are we seeing that? I mean, are we getting that immune response from this shot, where we are then immune to what it is that, the virus that we're dealing with?
Well, and that's a very interesting question, because that's what one would want to achieve, and that's what's being advertised. But these are what I call a leaky vaccine. So in vaccinology, you want something that's going to halt whatever virus you're exposed to or bacteria, whatever the vaccine is against in the future. It should keep you from getting that virus if you have the appropriately mounted immune response from that shot. What we're seeing here, and what their end goal was, instead of saying, well, we want something that is what we call a sterilizing immunity, it completely wipes out any future infection. What they said as their end goal in these trials was, okay, if we give the shot, does it decrease severity and symptoms, or does it decrease hospitalization? Well, again, by definition, that's a therapy. That's not a sterilizing vaccination. So we're most certainly seeing a significant breakthrough of people getting reinfected now who have had the vaccine, the quote vaccines. In the UK, just yesterday, one of their health ministers reported that 60% of their hospitalizations have been from those who have received both shots so far. On the island of Cyprus, one of the most vaccinated nations on Earth right now, they're having huge breakthrough numbers, the majority of which have been in the double vaccinated as well as the island of Gibraltar, with small population, but again, one of the most vaccinated islands. And they're one of the top, those two islands are one of the top, or two of the top 3 case rates in the world right now, in spite of receiving these vaccines. So even though they're being advertised as, an anti-SARS-CoV-2 vaccine, we're seeing significant breakthrough in those vaccinated. Now, that's because we gave a shot against last year's strain, and we have this concept that, oh gosh, well, it should cover anything going forward. Well, we know it doesn't. So the Delta is breaking through the Wuhan sequence. So the Wuhan sequence is, from 17 months ago, and the virus is shifting, and we're only giving a vaccine against this little tiny part of the virus, the spike, just the tip of it, whereas those who've had a natural infection are broadly immune because they have antibodies, hundreds and hundreds and hundreds, if not thousands of antibodies against all parts of the virus, that little ball of the virus, the envelope, the membrane, the nucleocapsid. So someone who's had a natural infection, we're seeing, tends to be broadly immune against future infection, whereas those who have received only a vaccine against this spike, and again, that spike itself, it can be pathogenic, they're breaking through because that lock and key where that antibody would bind and neutralize that spike, the lock and key doesn't fit anymore. And so these individuals are more susceptible to be reinfected. Now we're getting, unfortunately, I would say skewed or even just disinformation here in the States. They're blaming all the cases on the non-vaccinated, whereas they're not even testing most of these individuals, and they're most certainly not tracking like they do in many of these other nations that have much more robust tracking systems. But the world data indicates that the majority of the hospitalizations and breakthroughs right now are in the post-double vaccinated or injected. So, no, it's not providing, broad immunity. And we're on the Delta, we're not on the early strains. And then one has to ask themselves, okay, going forward, are we going to keep trying to chase a variant? By the time they roll out a booster for this or a booster for that, what strain or variant will we be on to next? And the challenge becomes, we really need to be focusing on early treatment because there are very effective early treatments that have been used around the world with much more success than a lot of the just big systems, governmental pharmaceutical protocols. And the point. Yeah. Go ahead, Carl. Dr. Karlfeldt.
And I'd like to get into that later on because I know that you are involved with the frontline doctors, and you run very very good protocols to address, in a much safer, cheaper way. But I wanted to kind of ask an additional question in regards to these spike proteins. So these different variations, we look at the initial variation, now we have delta variation, and I know I've spoken to epidemiologists, and I said there's at least 200 plus different variants out there, and this was like a month or so ago, so I'm sure it's even more now. So wouldn't it make sense, and if we're creating this virus or we're creating this vaccine that's producing these spike proteins, do all the spike proteins look the same, or like you're saying that the lock-in key is different now with this variant to this spike protein than the spike protein from the initial virus? Am I hearing you correct there, that they're different, the key is not fitting on this spike protein versus the other one in the past?
Correct. So as the mutations occur, you get a deletion of a base pair within the RNA sequence. Now you end up missing an amino acid, which makes that protein fold differently. So in one variant, you may have an addition of 2 amino acids and a deletion of 3 or 4. And so each time you do that, it's like grinding the teeth on a key. So each time that key now appears differently. So to your point, some of these are very similar, but they're not quite twins, but others are not even siblings in terms of that spike protein. And the majority of the mutation that happens occurs on that spike protein. So if we're trying to immunize against just that spike region, we're bound to have escape from that sequence.
Yeah, so and I think that is an important point, because most people, when they hear the word spike protein, they think that all the spike proteins look the same, that they are unchangeable. And yes, the virus mutates, but at least the spike proteins are the same. So if I'm so-called immunizing myself against the spike protein, I should have a defense.
Yeah, and it's interesting because so Israel is one of the most injected, immunized, countries on Earth right now, but they tried to look at the efficacy against, say, the South Africa strain, and they realized in that it was only in maybe 30%. The Delta strain, we heard in the news, okay, these are 95% effective, but they say effective. They didn't mean it's sterilizing or neutralizing against virus. They meant at decreasing symptoms. Well, with the Delta breakthroughs, there's a 7 times increase in those vaccinated over those who've had a natural infection in terms of breakthrough cases. And so this Delta strain, those shots are, again, 30% less effective than originally advertised, because to your point, these spikes are, you may be at a family reunion and say, okay, they look like they're family, but they're maybe, second, third, fourth cousins. They're definitely not the same anymore. And so now it's drifting enough that what we're chasing is much less effective.
Great. Well, let's take a quick break. You're listening to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Ryan Cole. We'll be right back. Welcome back to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Ryan Cole. So you made an interesting point. I mean, obviously, all your points are interesting, but so the vaccinated people, just kind of going back to what you were talking about before, I mean, I think the term that you used and other people used in the past is this process of immune priming. So if you are then getting the vaccine, you're then priming yourself, so to say, to this specific virus or something that is similar to that. So wouldn't that be a good thing, that your immune system is primed against that?
Well, you want it, so an antibody, when your immune system goes through this process, you want to be able to directly recognize that pathogen. Certain viruses don't mutate much over time, so when we get immunized, or if we get an infection, say chickenpox as a kid, we rarely to never will get chickenpox again unless our immune system becomes incredibly weak and our body loses that antibody. Or say measles, say grandma had measles when she was 5 years old, and 80 years later she still has a good, strong antibody. So you want a good, strong antibody. An antibody is forever, and you want a good one that will fight off disease in the future. However, if you make an antibody that is good at first, but now it doesn't lock and key, it doesn't bind because the shape of the pathogen has shifted just enough, now that antibody does become your enemy instead of your friend. So it will, instead of neutralizing the proteins that it's attaching to, it will bind to them, but it doesn't shut down, and now your immune cells gobble it in, and then your immune cells, it's kind of like a Trojan horse. The virus, those poorly formed, bound but not neutralizing antibodies, allow the immune system to gulp the virus in. Now the virus is inside of our immune cells, and it hijacks the immune cell function, replicates itself within the immune cells, and causes horrible hyperimmune reactions. Now, we've seen this in the previous coronavirus vaccine trials. We've also seen it with other vaccines against, say, dengue fever virus in the Philippines. And we saw a tremendous uptick in death amongst children, as well as hospitalization and severe disease. And those who thought they got a good vaccine formed a good antibody against dengue fever. But the next season, we actually saw a severely worse problem in those who had been vaccinated, because they'd been primed with an antibody that seemed good at first, but down the road ended up actually being an enemy to the immune system.
So you're actually, if I'm hearing you right, is that you have these antibodies and they're ready to kind of lock on a specific virus, a specific pathogen, and they're seeing something similar, so now they are hyper-reacting. I mean, their reaction becomes stronger, but they're not able to neutralize it because they don't have the perfect lock and key anymore.
They're not able to neutralize it. So when that antibody binds, there are parts of it that close and turn off, and then the immune system says, okay, that's closed, it looks yummy, my Pac-Man cell will go gobble that up. Instead, they have this little end of the antibody bound to the virus, this little tail flapping in the wind, and then the immune system says, not sure quite what to do with it. And that ends up docking with some of our immune cells instead of being gobbled by them. So the mechanism that's supposed to happen doesn't happen because they're not neutralizing anymore. So to your point, yes, they're locking on, but they're not neutralizing it. It's this whole it's this whole very, very involved process from an immunologic point of view. But the point being, when the virus keeps mutating like this, those original antibodies that one has formed, and again in a very small cluster, because we're only focusing on maybe a few dozen antibodies to the spike, and this is far different in a natural infection, because all those other antibodies in a natural infection, you formed good ones that will stay good because that membrane and that nucleocapsid, that envelope, that ball of the virus, those aren't the areas that mutate. That's why we're seeing these breakthrough infections in those that only have an antibody against the spike area. Those who have antibodies against the whole virus, we don't expect to see the same problem, because even though you may have a few that aren't neutralizing anymore, you still have hundreds of others that are. So it's very dangerous to be approaching the spike thinking, okay, we've made an antibody and we're good, but we do know how quickly we're seeing mutations. And the question is, down the road, how much more bad reaction are we going to see, because now we're harboring this induced antibody that at one point was good and then becomes less useful to us.
And like you're saying, I mean, we're seeing a huge amount of immediate reactions, but we have no idea what the long-term effect is going to be, because we're it's almost like you're opening Pandora's box. I mean, you have no idea what it's going to look like a year from now, 2 years. You're seeing increase in cancer already, and female cancers, and we're seeing also that downregulation of CD8, the T cells that protect ourselves against cancer, and we're seeing a downregulation our ability to fight viruses, and that's just right now. But 10 years from now, what are we looking at? Like you're saying, these antibodies, they don't escape. When I'm talking to Dr. Don Huber, he was saying, once you're injected, it's irreversible. I mean, it's not like you can take him out of you, right?
Correct. Yeah, he's absolutely correct, and that's my concern as well. A good antibody is great if it lasts forever, but if you form an antibody that's bad, it also lasts forever, and now it becomes your enemy, and it can trigger those other immune pathways. It can trigger enhanced disease down the road. It can trigger even autoimmune self-attack. And again, those shifts in the immune cell ratios I was talking about at the beginning, we don't know how long those shifts last. And if we don't have those strong T cells that we normally need to fight off other infections and other cancers, we've literally, opened up that can of worms, that Pandora's box. And this is why we do long-term trials on any therapy, on any vaccine, on any medication. We do it for years before we release it to the market. And then when we do see even an inkling of an adverse signal, we pull those drugs or those therapies from the market. And here it's befuddling in the sense that usually the FDA has a stop valve. If there are 25 deaths from a vaccine, they will pull that from the market. But because these aren't approved, these are emergency authorized, they're keeping the authorization going, and they're not halting when ethically, morally, scientifically, it would be the only thing to do at this point.
Yeah, I agree. Let's take a quick break. You're listening to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Ryan Cole. We'll be right back. Welcome back to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Ryan Cole. So so now, I mean, like you were saying, when we're rolling out a vaccine or any kind of pharmaceuticals go through different phases in trial, and it seems like right now, and usually, the like phase 3 trial, where you have a certain amount of people that you're testing it on, it looks like our phase 3 trial right now is pretty much all of the population of the world.
It appears that way. Yeah, that's the way I interpret it right now, because we're still gathering data. We're seeing the adverse events and the poor safety signals at this point. The good news is it doesn't happen to everybody. That's good news. The bad news is it's happening to more than we would ever allow in any other therapeutic trial.
Yeah, exactly. And one thing, we had after World War II, we had the Geneva Convention, and it almost seems like we are going against what was decided at that time. I mean, we are forcing something that has not been proven to work. I mean, it's still an experimental vaccine. I mean, we're investigating it. We haven't decided if this is a good one yet. We're investigating it.
Correct. And even in the emergency authorization, it says these are investigational vaccines, and it clearly states in the emergency authorization that these are optional. And we're pushing people to get them, and when we're violating that Nuremberg Code that basically said, look, we will never, without informed consent, we will never experiment or coerce humanity into an experiment again. And we're literally experimenting upon hundreds of millions of people without long-term outcomes being known. And then in addition to this, these non-approved, just emergency authorized vaccines, we have employers using them coercively to fire people if you don't participate in a human experiment for which the side effect may be death. Then they're reserving the right to fire you, which is completely unethical.
Yeah, well, and so in the beginning, when I so rudely interrupted you, you were starting to talk about that there are therapies out there that are really inexpensive, very safe, very effective, and I know that you have worked a lot with them, and a lot of your colleagues have worked a lot with them as well, with fantastic results. So tell me a little bit, and I mean, obviously the two that have been in the media a lot is the hydroxychloroquine and ivermectin. I'd like to touch a little bit on the ivermectin, because that's something that I use a lot in regards to cancer therapy, even though it is an antiparasitical, but it is something that has a huge amount of function within the body over and above that. Can you explain a little bit how ivermectin works and how it can be beneficial and what functions it has in the body?
Yes, thank you. And the point I always like to make is these are molecules, and they don't read a textbook. And even though it was approved for a certain indication, antiparasitic, well, as a molecule, it does a lot of other things as well. And fortuitously, to the benefit of humanity, it has multiple antiviral effects as well as immune modulation effects. So against SARS-CoV-2, and not just SARS-CoV-2, but against multiple other viruses, it has antiviral effects. So with SARS-CoV-2, it blocks the spike protein from binding at the receptors that allows the virus to latch on and enter our cells. So that's one step. Number two, there's a little protein, a little taxi that the virus would hijack and ride into the middle of our cell where it's going to replicate. So ivermectin blocks and binds that taxi, so now the virus doesn't have a little taxi in. Ivermectin also blocks this little folding enzyme that keeps the virus from folding and unfolding itself so it can't copy. That's called NF-kappa beta. And then there's another one. The virus has this little zipper called an RNA-dependent RNA polymerase. So ivermectin binds and blocks the virus from being able to zipper itself so it can't copy. And then beautifully, ivermectin tickles the nucleus of our cells to make our own natural interferon, which strengthens the other cells and boosts our immune response into a calm viral fighting immune pattern and not this cytokine storm Th2, this very inflamed pattern. So it modulates there. But the most important mechanism that ivermectin does is on our platelets, our clotting, our little pieces that help make clots, and on our red blood cells and on our blood cell lining, we have a receptor that the virus is hijacking. It's called the CD147 receptor. The virus will bind there and start triggering lots of clots. Well, beautifully, ivermectin displaces the virus from that receptor, pushes it off, and then inhibits this clotting disease that SARS-CoV-2 is. And there was a good paper in Nature just about 3 weeks ago that showed about 20-plus mechanisms of action of ivermectin, both against the virus and in modulating the immune system. So yes, even though it was originally approved as an antiparasitic, we've known for about 12 years in the laboratory studies that it has many antiviral effects, and now we're finding it's very highly efficacious, especially when given early. It'll decrease the death rate from anywhere from 86 to 90+% when given early compared to the other modalities that are being used within society. If used late, it still decreases the death rate over a lot of the hospital system and federal studies by about 68 to 70%. And these are in huge trials of multiple randomized controlled, placebo-controlled trials around the world, and you add up the data from countless trials of 26, 29 RCTs, and there's only about a 1 in 4 quadrillion chance that ivermectin doesn't have an effect against the virus.
I would say that's a pretty slim chance.
Correct.
And so what would be an appropriate dosage for, I mean, obviously we're just doing a blanket statement and an individual should meet with their doctor for the appropriate dosage, but what have you seen be an appropriate dosage just kind of as an average?
On average, 0.2 milligrams or 200 micrograms per kilogram has been kind of the standard dose. With the Delta variant replicating a little faster, the frontline critical care doctors, and these are some of the best critical care doctors in the world, flccc.net, they have all the protocols written out. So they've doubled the dose to 0.4 milligrams per kilogram. So when one's treating the virus, we'll usually do that dose and do it for 5 days in a row. If pulmonary symptoms continue, you can do it for 5 additional days. if you start a patient early on that, in my clinical experience, I've seen about 96% of patients resolve symptoms down to just a mild sniffle within 24 to 48 hours. The key is the earlier the better. It's like with any pneumonia in the body, any disease in the body, you don't wait till the patient's critical and in the ICU. You certainly treat them in the outpatient setting early and as quick as possible, and then you do avert worse disease. So it's interesting that we have these, and our government, a year and a half into this, still has no outpatient protocol. But there are brilliant doctors around the world that have come together for humanity and come up with these protocols. And I try to adhere to the FLCCC.net protocol. Those are brilliant physicians. I've consulted with many of them, and I've seen great efficacy in countless patients.
And is there a benefit one versus the other? I mean, hydroxychloroquine is another one that's been really helpful. I mean, is there one that's better than the other, or either one would work, or should you do both at the same time?
You can do both at the same time, especially if the patient is fairly severe, but you're still catching them early. Hydroxychloroquine, in some of the studies I've seen, it's been very good as prophylaxis. Once the patient is, say, day 6, 7, 8 of the disease, hydroxychloroquine isn't as effective. It has 9 or 10 mechanisms that I know of. It's not quite as effective. I know there's different camps. I think it does block the spike from binding as well. It does have some intracellular modifications of acidity and things like that to keep the virus from replicating. Obviously, we use it for arthritis and lupus and other inflammatory diseases, so it does have some nice anti-inflammatory actions as well. Ivermectin, in my experience, you can use early, mid, and late because of some of the stronger immune modifications. I think they're both effective early. I think they do have different mechanisms, and I think it depends on the condition of the patient which one you use at which point, and that's where you have to really rely on the clinician's experience at that point.
And with ivermectin, is it something that you can take prophylactically, like take a dose once a week or something like that? And
this is a beautiful study that came out of Dr. Carvalho in Argentina. He took 1,200 healthcare workers. 800 of those healthcare workers during their first wave, he gave them a dose a week for 2 months. And during that period of time, out of those 800 healthcare workers, 0 acquired COVID. Whereas in his placebo control group of healthcare workers, 58% of those other 400, 58% ended up with COVID, the ones who didn't get ivermectin. So his was the kind of the pioneering prophylactic trial. I'm hesitant. Yeah, I know what some of these medications can do, to the microbiome. You don't want to shift your microbiome too much. So sometimes I think, if you've been exposed, it's great to take a prophylactic dose, and or if you're in a setting where you're constantly exposed, it may be better like those healthcare workers. But other patients, it may be better just have it on hand in case you have a close exposure and or start early symptoms. So I'm not one to say, take a drug every week no matter what. I think, again, there's prudence in the approach to some of these things. And if you've had COVID, then obviously you don't need these medications.
No, exactly, because then you have a natural immunity. And
correct.
And one of the things with vaccines, is that they tend to bypass the innate immunity response. So how does innate immunity relate to what's going on with this vaccine? I mean, are we impacting it?
We are. We're weakening it based on some of the blood profile studies that are coming out from laboratory studies around the world. With the shots, we're weakening the innate immunity. That's that broad array of T cells. I kind of call it your Marines. They're the first one in to attack the invader. And you want that to be strong and robust. This is why children do so beautifully against this virus, is they have a strong innate immune system that immediately attacks when they get an invader. Well, you want that to stay strong and robust, and there are ways to keep that. Obviously, some of the things that you do with natural health, sleep, rest, low stress, those are things that keep our innate immune system strong. But we are seeing indications that are very concerning that post-vaccine we are losing some of that innate response. And again, we don't know for how long. But I am concerned as a pathologist that studies these things and studies patterns. Again, we're not being prudent, unfortunately.
No, exactly. Well, Dr. Cole, thank you so much for giving us all this information. I mean, these are crucial information for people to appropriately make decisions in regards to whether this vaccine is good for them or not.
Can I make one real quick comment? 1 second real quick? And that's
absolutely.
if you've had COVID, to get the vaccine puts you at a multiple-fold increased risk of adverse reactions because you do have that broad natural immunity already. And if you trigger it again with a shot, so many of these patients are having so many adverse reactions above and beyond if you hadn't had COVID. So I really believe in this concept of screening before getting a vaccine. If you feel like you need the vaccine, again, I'm not anti-vaccine. I'm pro-good science. I think the good science isn't here yet. But if you think you need it and you don't know whether you've had COVID or not, check your antibodies, check your T cells, because otherwise you're literally putting your immune system and your health at risk.
Yeah, thank you for that. And obviously the best thing is to support your immune system with natural things, vitamin D, A, C, zinc, those kind of things, and quercetin, NAC. I mean, those are good things to do, and that way your immune system is just stay strong. And when you're exposed to all these different pathogens that we're exposed to every day, and we've been through eons of time.
I agree.
Yeah, great. Well, thank you so much, Dr. Cole. And that is it for today. You're listening to HealthMade Radio. Remember, check us out at healthmade.co. Health is what you make it. 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 Is what you